Hello, everyone. Welcome to the Society of Pediatric Echo new academic year, 2023-2024. My name is Neha Soni Patel, and along here with Dr. Jen Kovu, we are the co-chairs of the Education Subcommittee here at SOPE. And tonight is our inaugural Fellow Echo Boot Camp, and we are so excited to have all of you here today. As you know, normally these speed webinars are normally 30 minutes long, but this is a special series for the next couple of sessions. This week's session will be 1 hour, follow up with a part 2 with another hour on September 12th. After tonight, mark your calendar. Dr. Ira Parnas will be presenting on segmental anatomy on September 12th. Jen will give you some more information.
All right, am I unmuted?
Yes.
All right, a few housekeeping rules for tonight's webinar. Please stay on mute as we will start with each speaker with their talks, and we will then proceed with the Q&A at the end of all three speakers. So please type in your questions at the chat box as well, or raise your hand during the Q&A, and we will unmute you. So before we hand them over to the moderators tonight, we would like to thank our institutional sponsors, Lurie Children's, Cincinnati Children's, Lucille Packard Children's at Stanford, Nemours Children's Health, and Seattle Children's. And if your institution is interested in being a sponsor, please email Tara Foy, and after tonight, mark your calendar for the part 2 of the Echo Fellow Boot Camp on September 12th. So we would like to hand this now over to the 2 champions of this inaugural Fellow Echo Boot Camp, Carolyn Wilhelm and Ray Lorenzoni.
Good evening, everyone, and thank you again for joining us. We have 3 great speakers for this evening's session. We also have our 2 of our fellow members of the SOPE Education Committee who will be our moderators this evening. That's Charlie Simpkin from Children's Hospital, Colorado, and Emily Ribeiro from University of Florida. So for all the fellows on the line, keep in mind you too can become more involved in our SOPE Education Committee in the future.
Wonderful. I'm Ray Lorenzoni. I have the pleasure of introducing Deborah Ho, who's our first speaker for the evening. She's coming to us, as you just heard, from Lucille Packard Children's Hospital. And she's a clinical assistant professor at Stanford, where she specializes in echo and fetal cardiology. In addition, she's the medical director of the Complex Biventricular Reconstruction Program and associate chief of ambulatory cardiology. She completed categorical fellowship in advanced imaging training at the Children's Hospital of Philadelphia. And I'll let her take it away with her session on boot camp and the standard pediatric echo. Thank you.
Thanks so much, Ray. If I can go ahead and share my screen. I'm really looking forward to speaking to you all today. You can see that okay? Yes, okay, excellent. So I have 20 minutes. I'm going to talk to you about echo boot camps, and then I'm going to talk a little bit about the standard pediatric echo views. So what is an echo boot camp? So I had the pleasure of being a part of putting together an echo boot camp in 2 places. So once in fellowship when I was a senior fellow at CHOP, and then also here at Stanford. And in putting together these echo boot camps and then speaking to others who have done them at other centers, I've come up with this loose definition, which is that it's a dedicated amount of time to introduce basic echo skills, which are 1, how to hold and move the probe, how to use the echo machine, where's the on button, how to acquire images, basic interpretation, what are these pictures representing, what are the normal views that we get, and lastly, what are some basic echo concepts? How do I optimize an image? What's color? What's spectral Doppler? How to apply the Bernoulli equation? So I think, this is what Echo Bootcamp means, touching on these 4 aspects. And why should we do ECHO boot camps? Well, there's quite a bit of data actually that shows that ECHO boot camps help our fellows. Starting from the paper that Texas Children's put out a number of years ago with follow-up and subsequent data. What we know is that ECHO boot camps, when you have that dedicated time towards teaching this complex skill, you can increase fellow confidence, increase knowledge and retention of knowledge. You increase quality and clinical performance, number and quality of echoes done over fellowship. There's a lot of benefits. And so really, if you're in a position as either a senior fellow or as a faculty member to find some time to put together an ECHO boot camp for your fellows, I really encourage that as a wonderful way to supplement fellow learning. So when thinking about how to put together an ECHO boot camp, I think there's three main considerations, essentially time, what your goals are, and how to incorporate different ways of learning. So the first question is, how much time do you have? Of course, it would be wonderful if we could all get, 4 dedicated days at the beginning of fellowship to learn all about ECHO, but that's not always possible. And I think it's not necessary. You can still do a lot with even just a half day of protected learning time. And of course, your goals may change depending on how much time you have, but I think you can also be creative. It doesn't have to be 3 days in a row where you're, immersed in ECHO. It could be half a day here, half a day there. And, I put in there weekend because over the course of the last couple of years, because of the orientation schedule for our fellows at Stanford, we actually have included a weekend day, which of course does take a day away from faculty and fellows on the weekend. But I really haven't had many complaints because it's really fun. We have our senior fellows participate. They teach each other. It's really engaging. And of course, there's also the benefit of being able to use the ECHO lab that's devoid of outpatients because it's a weekend. So all those reasons to think outside the box and potentially even consider a weekend. So here's just a couple of samples of different schedules that we've worked with over the years. At Stanford, we've condensed our ECHO bootcamp. It's 2 days. One thing I really think is helpful is having the different types of learning. And so you can see in color-coded blocks here, the blue is kind of more traditional lecture in which we talk about 2D and Doppler and then introduce the views, followed directly by hands-on practice. And so we find that our fellows have told us that that helps to cement their knowledge by being able to apply and put, to practice what they've just learned. We also have what we call Read Together, which is also lecture-based, but it's where we all sit together in a room and we look at an ECHO together. So that's kind of learning how to start interpreting images. The second thing is, what are your goals of ECHO Bootcamp? This is going to really be tailored to the amount of time that you have, right? And so if you have more time, of course, you're going to be able to potentially accomplish more. For example, get fellows to be able to complete a protocol, for example, or do you just want to create some familiarity with all these terms and these views so that when they're doing their on-the-job learning, it's not the first time. The last thing I think is really key in ECHO Bootcamp is the idea of multimodality learning, or trying to engage learners from different perspectives. I think particularly when it comes to something so complicated like ECHO, where you have to look at two-dimensional pictures and create a three-dimensional understanding in your mind, while also manipulating a probe in space with gel. That's a lot of things. And so it's helpful to come at these different pieces of understanding from different perspectives. Self-directed learning is kind of our classic, way that we would learn in fellowship. You would learn on the job and then supplement with reading. And so, of course, we do encourage pre-reading for our fellows. I always refer to the ACE guidelines. It has some really wonderful diagrams in there. And there's some also really helpful online modules you can access these days. Lectures, of course, are kind of essential for that knowledge transfer and for image interpretation. But hands-on practice, I think, is a critical element. This could be as simple as making an agreement with your co-fellows to come in on the weekend and scan each other, or in a more formalized boot camp, having live models recruiting children of faculty or staff at the Heart Center. I think simulators, if that's a resource that you have access to, are fantastic. During the pandemic, we actually transitioned our boot camp to a completely sim-based model, and our fellows still got a lot out of that. And there's data to show that simulation training can be really beneficial to fellows in fellowship as well. One thing to remember if you're putting together a boot camp and you're going to be recruiting models is, what are you going to do if you find an abnormal finding on a volunteer, like a silent bicuspid aortic valve or an anomalous right coronary? So it's good to have a protocol in place in advance that you're going to refer them, or, in some labs, they don't really think that that's appropriate, in which case they may recruit from their patient population, someone who's got a ASD that was closed, who's got a transplant with good windows and normal anatomy, something like that. So those are some considerations. And the last thing is, I think, don't be afraid of repetition. Repetition is our friend when our fellows are really drinking from a fire hose and trying to absorb a lot of information. Sometimes even having somebody else say the same thing can help someone understand it better. If you have access to additional learning resources, that's wonderful. At Stanford, we're really lucky. We have this virtual reality module that where fellows can put on these goggles and actually blow apart a heart or look at it from the inside. The videos that accompany the LIADAL text and the text itself are critical, I think, for learning when you're getting started. And Texas Children's has a wonderful online learning module that they actually have published on recently that's been shown to help with fellow learning beyond participation in boot camp. But all of these things cost tens of thousands of dollars, but you don't need to do that. You don't need to break the bank to put together a nice Echo boot camp as we're in right now, for example. But I know every Echo lab has one of these kicking around in some dusty corner. And all you need is this plus a $15 giant protractor from Amazon.com. And this is one of the most important and helpful tools that I use when I'm introducing fellows to new views, because we use this protractor to demonstrate what's our imaging plane and why does the picture look like this when we're cutting through the heart. It's because this structure is in front of this structure and more anterior and whatnot. So all you need is this to achieve that learning sometimes. Okay, on that note, I'm going to shift a little bit. I'm going to talk about some peds echo views. Obviously, if I could teach pediatric echo views in 10 minutes, then fellowship would be a lot shorter. So what I'm really going to try to do is focus on some pearls in each view that you can think about as you're learning. So, sometimes we think about the heart sitting like this, atrium up top and ventricles in the bottom, but of course that's not how the heart sits in the chest. And that's a critical piece of understanding when you're looking at echo images and trying to make sense of it all. And what I like to tell my fellows is, think about the left atrium in the middle, the most posterior, sitting in the carina, just under the carina like this. The left ventricle, of course, points anteriorly and to the left in a normal heart. And the right-sided structures, even though they're to the right, they're actually mostly anterior to and wrapping around those left-sided structures. And that's a really important concept, that the right-sided structures are anterior. The other concept I want everyone to think about as you're learning your views is the concept of what I call objective versus relative planes. There are planes in which every time we do an echo on every person, no matter where their heart is, levocardia, dextrocardia, you put the probe in the same place and you make the same motion. And so I think of the subcostals and the suprasternals in that way. And we use these views in order to understand the relationship of where the heart is to the rest of the organs. And so you do the same motion regardless of where that heart is. Whereas there's also relative planes. So if you have a dextrocardic patient and you put your probe leftward and anterior, you're not going to get an apical four chamber, right? So you have to put it where the apex is. And so thinking about those differently is important. In the subcostal long axis, I think this is a really good demonstration of how echo is a different imaging modality from, for example, CT, where every slice is parallel to the slice before. So in subcostal frontal or long axis, you start with an anterior posterior kind of picture, and then you move towards an inferior superior picture because you're dropping that probe, you're changing your plane of inclination. So as you're looking at every picture, as you're starting to familiarize yourself with the images, really try to think about which part of the body is where. Because in subcostal frontal or long axis, we've got right, left here, but as you turn your probe into your sagittal view, you're now going to be looking anterior is this part of the screen and posterior is this part of the screen. And that doesn't change because you're now sweeping left to right. And so that's just important to keep in mind as you're looking at these pictures. In the subcostal frontal, when you're sweeping, your liver should look nice and flat, and actually your atrial septum should also be parallel to that. Sometimes as we're sweeping, it's very natural to turn a little bit clockwise, and that will give you kind of a atrial septum that's a little bit 45 degrees, and then you've really come into kind of left anterior oblique LAO territory as opposed to true subcostal frontal. The other thing I like in this view is that you have a little bit of extra space above the heart, particularly in babies, because there's information up here that you can see. For example, where does the descending aorta come down? Is it on the left? Then you know you have a left aortic arch. The other thing to note is you want a heart not in a snowstorm. You want that background darker than what you're looking at in the center. In apical 4 chamber, I think this is one of the most intuitive pictures to look at, but one of the hardest pictures to get. And so don't let lack of gel be the reason you're not getting good pictures. Sometimes a little extra gel can help you maintain that contact that you need to really get a nice 4 chamber sitting straight up in the view. And as you sweep forward, sometimes if you want to try to get that pulmonary outflow, which you can in particularly babies, sometimes if you come a little bit medially, that will bring that right in. Peristernal long axis, again, one of our quote unquote relative planes. And so what you want to do is you want to really line yourself up with the LV outflow tract. And in a normal person, that's going to point up towards your right shoulder. Now, that's really important to remember that by convention, the long axis is the only time that we have our probe marker over on the other side of the patient. And so in our lab, we always have the probe marker to the left of the patient, but in long axis, we do it to the right shoulder. And that's just something important to remember because it does mean that your picture becomes slightly left, right, reversed. So when you are scanning and you're seeing a pulmonary artery in your long axis, remember that because of that convention and we're slightly left, right, reversed, this pulmonary artery here, that's a left pulmonary artery, not a right pulmonary artery. When we're looking at peristernal short axis, my tip is about coronary. So once you've got your on-fast view of the aortic valve like this, remember that coronary arteries don't stick out like wings. They actually come, they follow along the ventricular surface towards the apex. And so in order to bring your left coronary artery in, you can just turn a little bit clockwise, and to bring your right coronary in, if you turn a little bit counterclockwise, sometimes that's what you need to do. Suprasternal frontal or suprasternal, looking at that arch branching, all that, I think is one of the most complex images to understand, partially because everything's a line and a circle. And so really familiarizing yourself with what's supposed to be there, what these structures are supposed to represent, can be really helpful. My tip here is about arch branching. How are you supposed to know where to follow the branching of the arch if you don't know what arch-sidedness it is yet? And there's a really quick and easy way to figure that out, which is to start with just a little mini sweep just for yourself. You don't have to clip it. And what you want to do is you want to follow your transverse aorta and see, where does it go down? Does it go down the left side of the mediastinum, in which case, there you are, it's a left aortic arch? Or does it go down the right side of the mediastinum, in which case it's a right aortic arch? And once you know that, then you know, now I'm going to look for branching for a left aortic arch. I'm going to look up and to the right for that innominate vein, innominate artery to branch. And if it's a right aortic arch, I'm going to look opposite. I'm going to look up and to the left for that branching of the great arteries. Suprasternal sagittal, technically not quite a sagittal. particularly when you've got a left arch, because that comes up into the right. And so it's really kind of rightward anterior to leftward posterior. So my tip here is sometimes in babies, the best place to get a really nice arch is not suprasternal, as the view is called, but actually just a little bit under the right clavicle, just next to the right of the sternum. It brings your probe kind of in this position, and sometimes that can give you a really nice view of the isthmus. So that was my quick overview of PEDS echo views. Hope those helped, and thank you so much for your attention and your time. I really appreciate the opportunity to speak to you all.
All right. Well, thank you so much, Dr. Ho, for that great introduction to our standard echo views. I now have the pleasure to introduce Dr. Dale Burkett, who is an associate professor of pediatric cardiology. He completed his training at the Children's Hospital of Colorado and University of Colorado, where he remains on staff today. He is currently the medical director of the echocardiography lab at Children's Hospital Colorado, as well as the director of 3D echocardiography and echo education. He'll be speaking to us tonight about the important topic of echo physics. So Dr. Burkett, I'll turn it over to you.
Excellent. Hopefully everyone can hear me. There's no issues with that. I have the daunting task of covering all of physics in a mere 15 minutes. So this will be quick, but we'll see if we can get through everything here. Okay, so I have no disclosures. We're going to go through some properties of sound, and then we're going to get into Doppler. And I'm going to spend the majority of time on Doppler physics and pulse Doppler, because that also applies to some of our other forms of Doppler. But I would highly recommend any fellow read this echocardiography book, kind of the fellow book for echo by Lai, Mertens, Cohen, and Dr. Gaba. It's excellent, and the first chapter there should be easy reading for a lot of the material here. So first, getting into the properties of sound. So sound basically composed of mechanical waves of compression, where things are being pushed together, and rarefaction. And so we often draw this as a sine wave, but I like this image above where you can kind of see the compression and the rarefaction. And so this is how things are going to move through a medium. It's important to note that we have a wavelength here, which is represented as lambda. That's between the two peaks or the two troughs, really anywhere, but that is one cycle length. It's important to note that sound wave in tissue, which is what we're talking about with echocardiography, moves very quickly, so 1,540 meters per second. Again, the wavelength is lambda, and frequency is inversely related to wavelength. And so frequency is described as hertz, or that's the cycles per second. So how fast that sound is moving is a constant, but how much wavelength there is in a given second is related to the frequency. And so we have different frequency probes. You have a 12, a 9, a 6, 4, depends on your system, but those are referring to the frequency that's being emitted from the probe itself. So that's the relationship there between the speed and frequency and wavelength. So piezoelectric effect is basically we can apply electricity to a quartz crystal inside of this probe, and it actually vibrates the crystal. And so that's what's actually emitting ultrasonic waves. And ultrasonic waves are basically moving at a frequency greater than 20,000 hertz. So it's too high, too fast to hear, but it generates an image. And interestingly, when that ultrasound image, those waves leave and they hit tissue, they reflect back towards the probe. They vibrate that crystal again, and that generates an electrical signal, which we end up seeing as an image on the screen. So these transducers, these probes that we use, again, they send out ultrasonic pulses, and then they're going to listen for that signal to come back. So depth is really important with ultrasound, because that determines how long it takes for the ultrasound to travel through the tissue, hit the target, and come back to the probe. And so time really is equivalent to depth, because the deeper the tissue, the more it takes and time to get there and back. And so that's an important concept, is that time and depth are very closely related in ultrasound. It's also important to note that higher frequency signals provide better resolution. So if you're going to be imaging a little baby, you're going to want to grab the 12 probe to get the best images possible and not use the adult probe. And conversely, if you're using the 5 megahertz probe or 4 megahertz probe, you're going to want to use that for the adults because the tissues are further away. So higher frequency gives you better imaging resolution because you're having more signals hit the structure and bounce back. So you actually get a little bit more detail with that. But higher frequency actually attenuates in tissue, so it doesn't actually travel as far. And so that's why you need to use lower frequencies when you're imaging deeper structures. So there's a relationship of depth, resolution, and frequency here that I think is worth highlighting. So if you're going to image things that are further away, you have an increased depth that's going to take longer time again. You're going to want to use lower frequency because it's further away, but you're also simultaneously getting lower resolution. Conversely, if you're imaging things that are closer at decreased depth, you can use higher frequency signals and you have improved resolution. So this is one of the common reasons that why when you look at an infant's echocardiogram, everything looks really great. And then you're going to look at your 25-year-old ACHG patient and you can't see much. Another interesting property of sound that's worth noting here is harmonic imaging. So as these ultrasonic waves travel through tissue, they actually get distorted. And so they end up being distorted in multiples, integer multiples from the original frequency. So I'm just going to show you here, if the original frequency was 1.7 hertz, there will be frequencies in the tissue that are going to be at 3.4 and then other multiples of 1.7. So we can actually use this to our strength because these harmonic frequencies can go stronger with distance. And so when you're imaging things that are further away, focusing on harmonics actually can improve your signal to noise. So the signal is the thing we care about, and the noise is all the things that we don't want to be imaging. And so using harmonics can actually improve that signal to noise ratio. And we can actually tell the probe to listen for harmonics. And so that's one of the noms that when you go through and you're learning this, you can be in a fundamental frequency or in harmonics where you're listening to harmonics. And the important thing with harmonics is that you get less grayscale and you actually also get less axial resolution. So less resolution along the beam. And sometimes things appear thicker. So this is a classic example here where we've done nothing other than turning from fundamental to harmonics, and you can see how much better you can see the mitral valve. But you'll note that the tissue here in the myocardium of the left ventricle actually is harder to see, and it just becomes more kind of black and white, and you lose that grayscale. So we're going to turn quickly here to Doppler physics because I think this can be pretty confusing, and it relates a lot to color Doppler, pulse wave Doppler, and continuous wave Doppler. So first off, Christian Doppler was 1800s, and he was the first person to describe that the observed frequency of light or sound waves is affected by the relative velocity of the source and the detector. And so this was all the way back in 1842. So this is nothing new. I think the easiest way to think of this is a siren. As an ambulance is driving down the street, you hear it has a higher frequency until it passes you, and then it sounds like it has a lower frequency as it goes by. So, so that's basically because the ambulance has a velocity. So if you're in the ambulance, it has the exact same sound the whole time that you're driving around town because you're with the source frequency. But if you're standing on the side of the street, as it approaches you, it has 40 miles an hour in addition to the frequency of sound. And as it drives away, it's moving away from you 40 miles an hour. And so that change in the frequency is known as the Doppler shift. So in ultrasound, this is important because the velocity of sound is fixed and the frequency that we're imaging is fixed. So really the only thing that's moving or shifting is actually the velocity of blood and the angle of interrogation. And so this is how we're going to use the Doppler shift to measure velocity. So this is the actual equation, and the Doppler shift is proportional to a few things that I think are worth highlighting. So first, it's proportional to blood velocity. This is important because if we're going to use Doppler to measure the velocity of blood moving through a vessel or across the aortic valve, that's why we're able to do this. It's also proportional to the probe frequency. So a lower frequency probe has a smaller Doppler shift. Okay, we'll get back to that here in a little bit when we talk about aliasing. The angle of interrogation is also very important. So that's the cosine here of theta. That's the angle of interrogation. So you want things in Doppler to be directly parallel to the beam. The further that you get away from parallel, it's going to start reducing the measured velocity artificially. And so again, if you look and said we're exactly parallel, well, the cosine of 0 is 1. So you're going to account for all of that motion towards the probe. And I think it's easier to highlight this here. So if this is the beam angle, and I'm trying to measure the velocity of this tissue, and that tissue is moving in this direction, this is the true motion, The only amount that you're actually going to measure is this, okay? And so if these two things are lined up parallel with each other, you can measure that entire actual velocity or motion. But the further that you get towards 90 degrees, the smaller this is going to be. And the cosine of 90 is actually 0. So things that are moving perpendicular to the beam angle, you can't actually code that velocity. So this is a great example looking at the air arch flow. You have red flow coming up towards the probe and blue flow going away. And we know that there's velocity moving entirely through this, but you can see here that this machine has to code it as having no velocity at 0 meters per second, because at this exact point, the flow is perpendicular to the beam angle. So we're going to get into some pulse Doppler now. Pulse Doppler basically is when the probe is going to release intermittent pulses sent out from the probe, and then it's going to travel through the tissue, hit a target, and come back, and the probe is going to listen for that to come back before sending out more pulses, okay? So this is really helpful for range resolution. So if we want to say, I want to listen to the aortic valve that's 10 centimeters away, you're picking a point along that range to say, I need to listen at this exact point. So that's range resolution, and that's why pulse Doppler is so helpful. So we can define that point in space because we have the cursor, and we have, it's easy to maneuver that cursor. You can change how the sample gate, but where you put that cursor is where you're telling the probe, I want you to listen at this exact spot. So this is where it's going to be a little bit more confusing, but I think this is helpful to understand some of the other properties of Doppler. But the time between pulses is known as the PRP, the pulse repetition period. And it's made up of 2 points. So the pulse duration, so this is the pulses that are being sent out by the probe. And then there's dead time. And the dead time is because the signal has to go through the tissue to the target, hit that target and reflect back, and then the ultrasound probe is going to, again, code that as an image or velocity. So things that are further away will take more time, so you'll have a larger dead time. Things that are closer have a shorter travel time, and so a shorter duration and a shorter dead time. And so the depth will change your pulse repetition period because you have a difference in your dead time, okay? So aliasing is an important concept. When we talk about aliasing, it's helpful to understand this. So aliasing is the inability to distinguish signals. So you can't accurately code a signal when it comes in. And this basically occurs when the velocity that you're trying to measure is too high for the machine to actually resolve. So we'll show you an example of this on this screen here in a second, but it's related to the PRP and the pulses that leave the probe. So the number of pulses that come out of the probe per second is known as the pulse repetition frequency, or the PRF, okay? To accurately represent any frequency that we're trying to measure, the pulmonary valve, the pulmonary vein, the mitral valve, we're going to call that the frequency of the Doppler, FDOP. So we have to sample that at least twice in order to determine what that frequency is. So that relationship here, PRF equals 2 times that frequency. So there is a signal Doppler frequency, some velocity of the aortic valve, beyond which you can't actually characterize it because it's moving too fast. So that's the Nyquist limit. So if we look at this little circle up here with a number, that number is the Nyquist limit. And so we have said we are going to listen for things that are within this velocity. And you can see it's a plus up here and it's a minus on the other side. So let's say it's plus 0.9 and minus 0.9. Well, on this image, you can see that this signal goes off the bottom of the screen and it kind of comes back on top. And so I can't tell you what the actual velocity of this is because it's gone too high. It's above the Nyquist limit. So the Nyquist limit is related to this frequency of the Doppler, and that we can reorganize this and say that it's the pulse repetition frequency divided by 2. So that is the Nyquist limit. So, and it's again related to the PRF, which is going to be inherently related to the probe and what we're looking at with our frequency. So in a pulse Doppler, aliasing occurs when the upper limit of that Doppler shift cannot be detected. So it's too fast, it's too high, we can't define what the velocity is. So again, I can't look at this aortic valve and tell you how fast that blood is moving. So that is aliasing. Now, interestingly, the PRP, the pulse repetition period, again, it sends it out, waits for it to come back before it sends it out again. That's related to the pulse repetition frequency, the PRF. In that the longer the pulse repetition period, the lower the PRF. And if we go to the next slide here, this is the way I think about this. With increasing depth, you have to increase the pulse repetition period because you have an increasing in that dead time waiting for the signal to come back. Because those are inversely related, that means that your pulse repetition frequency decreases. I can't send out as many pulses in the same time frame. And so because of the PRF is related to the NICOS limit directly, as the PRF decreases, so does the NICOS limit. So what does this mean in application? If you are imaging something and you're aliasing, then it's because your NICOS limit is too low. So how do we fix that? Well, first is try to increase your NICOS limit. Can I increase the scale? You actually can. And a lot of times that will fix the issue, but there's only a certain amount that you can do that. The other thing you can do is get closer to the interested object. So if you move closer, you're gonna shorten the PRP, and that means you can increase your PRF and therefore your NICOS limit. So if you're trying to image something that's 10 centimeters away, but you can get somewhere that's 5 centimeters away to image the same thing, you'll actually get a better, higher NICOS limit. You're gonna grab a lower frequency transducer. And so if you use a lower frequency transducer, you get a smaller Doppler shift. And again, that kind of goes back to that actual Doppler equation. So if the 12 probe is giving me aliasing, grab a 6 probe or a 4 probe, and you often can get the same pulse without having any aliasing. And then the last thing is if none of those are working, you end up having to use continuous wave Doppler. And so in continuous wave Doppler, it's continuously sending out a signal and continuously listening. But the problem is that by doing that, I can no longer say, I want to listen to that one object that's 10 centimeters away. You're listening to everything along that beam angle, and you have the ability to get really high velocities. You can see here we're over 5 meters per second. But the problem is you lose range resolution. And so this is a classic example in some of the tetralogy of flow where you're getting a double envelope because you have velocities of the valve, but also at the RVOT, but you can't really say where that is anymore. Turns out there's a lot more to physics in echo than just this. So I again highly recommend you look at that book, and I can try to answer some of the questions in the chat after this. Thanks.
Thank you so much, Dr. Burkett. Our next speaker is Laura Pizzava. She is the Education Coordinator for Children's Mercy Echo Lab in Kansas City. In addition, she's instructor for the Cardiovascular Sonography Program for the Pediatric Track in the School of Health Professions at the University of Kansas Medical Center. And tonight she's going to be presenting echonobology.
Hi, and thank you so much for the chance to talk about knobology and echo optimization. So many knobs on ultrasound machines have the same name, although vendors may develop different ways to optimize. So my terminology is informed by the machines I scan on, which here at Children's Mercy, we have GE and Philips. So if your institution has a different vendor, you'll notice some differences, but they'll be minor. What is knobology? Well, this is manipulation of the knobs and controls to obtain the most diagnostic image possible. Image optimization is manipulation of the machine settings, patient positioning, probe adjustments to obtain the most diagnostic image possible. We need to keep in mind 3 things. First, don't be distracted when you look at all the options. There are way more buttons than you will ever use, and it can be overwhelming. So you need to learn the most frequently used knobs and memorize them. And you need to learn how to reset your machine when you go down the rabbit hole because you've changed so many knobs. So we're just going to approach this like we're going to go together and we're going to scan a patient. So what are we going to do? We're going to get our machine, and you need to know how to move it, how to raise it up and down. Can you lock it into place, swivel and adjust your monitor? You need to think about ergonomics when you're scanning. Going to turn it on. And then you need to connect your EKG and enter your patient either workless or manually. Every institution will have a different way of doing that. We need to decide what probe are we going to use. And this is generally driven by the patient's age and weight. For the neonates, like we talked about in the physics lecture there, you're going to use your high frequency probe, usually the 12 probe, up to about 3.5 kilos. Infants and children up to 50 kilos, you're going to use your pediatric probe. This is the 9 probe on the Philips. And for children and teens over 50 kilos, you want to use the adult probe, which is a 5 probe, and it's usually a 3D probe. And just remember, for some patients, you're going to use 2 probes. It may not be enough to just one. You're going to switch back and forth. So every probe, we've chosen the S9 here at the top, is going to have a preset. And the preset, you can have a factory setting, which is what the machine manufacturer decides. This looks good. This is where we think it's a great place for you to start. If you're lucky, your institution is going to have their own preset that they have adjusted the depth, the 2D settings, the color, and the Doppler settings. So it's a really great place to start. If you choose wisely, then you're going to have an easier time getting your images and have to optimize less. I always tell the fellows, a good preset will set you up for success. So as we start scanning window to window, if you have this little checklist in mind, it allows you to quickly optimize so that you can start to spend more time getting a great image and trying to understand your anatomy. So we'll kind of repeat this window to window. The most frequently used buttons are located near the trackball and the kidney key in the center of the deck, and the touch screens are usually organized so the most frequently used buttons are on the first page and not buried on the next page. Ideally, you won't have to do a lot of reaching and searching. We've chosen our probe and we've chosen our preset, and now you have to think about the frequency. Each probe has a range of frequencies with harmonics, no harmonics, res, which is on Philips, a higher frequency probe, general, and then you have a penetration setting for the lowest frequency. GE has the same kind of a button. It's called an octave, but they do essentially do the same thing and allow you to toggle through frequencies. Your goal is to use the highest frequency probe for the best spatial resolution, but also you need to have adequate penetration. So this is just a couple of images of what the knob looks like. You're just going to turn it. It's very simple to optimize. So this picture is a 79-year-old teenager, and the picture on the left, this was taken with the adult probe, this was taken with the pediatric probe, and this is with the 12 probe. And the point is, just remember, it's not just one probe fits all. Sometimes you need to switch around and you might get lucky and get a nice image with a different probe. So we're going to start with our checklist now. We've got our probe, we've decided the frequency, we've decided the preset, put our probe maybe in the subcostal window, and we're going to first thing optimize your depth. So your depth increases or decreases the field of view. If you have insufficient depth, like this image here, you will not display the anatomy that is of interest. You're cutting off some of the atria. If you have excessive depth, like this image, you're not going to be able to visualize everything that you need, maybe finer details. This image is optimized depth. You see what you need, but you don't have distractions. Then we are going to move on to the gain. We've got a nice depth. So now we look at our image and we think, how can we make it better? The gain controls the amplification of the displayed image. The goal for cardiac structure to show up as shades of gray, and the blood pool should be almost black, and it should be uniform top to bottom. There's a few ways to optimize gain. The first thing you can do is your eye scan or your automatic gain button, and then you can do your overall gain button. You have TGCs and then you have LGCs. So the eye scan or the automatic gain button is just a one-touch button. You hit the button and the machine's going to automatically adjust the brightness and gain from top to bottom to something that should be a fairly good starting point. Sometimes that's all you need to do. But let's say it doesn't do enough. So then you're going to go to your 2D gain button, which just you turn it up or down to increase or decrease the overall brightness of your image. Undergain images will be too dark and anatomical information could be missing. And then overgain images will be too white and snowy and anatomical detail will be lost. Both lead to suboptimal visualization and errors in measurement. You can even get artifacts if your gain settings aren't great. So we've hit our eye scan button, we adjusted our 2D gain. Now we can look at our TGCs if we need to make some finer adjustments. These are the little slide pots on the left side of the control panel, and they can adjust for your gain based on your depth and signal attenuation. Often you are going to need to decrease your gain in the far field, so you'll slide the little slides to the left. You can increase your gain in other areas if you need. And remember that this is something you are going to probably adjust in every window. You also have lateral gain compensation, and this compensates for gain attenuation across the sector side to side. So what you're going to do is you're going to hit the touch screen, touch this button here on the Philips. You have this horizontal line. You're going to take your finger and drag it up to add gain to enhance whatever part of the sector needs improvement. Okay, so we adjusted our depth. We've got our 2D gain set. Now we need to talk about our sector size. That's the size of the pie. And as you decrease your sector size, you're going to improve the resolution by dropping off scan lines of peripheral structures and focusing on the region of interest. This is going to improve your frame rate. You want to have it, greater than 30 frames per second is something to shoot for. And then if you decide, I don't like that, I need to figure out how to get back to just my 2D sector, you're just going to hit reset and you'll go back to your default setting. This image on the left here is a really nice image. The sector is as wide as it will go. However, our frame rate's 49, which is still good. You can see the right coronary. But then on this image, we've decreased our sector width. So our frame rate's almost double now, and we can really see that right coronary if we needed to measure it. So when you look at your machine, you're going to see all these options for ways to change the 2D appearance. But I would tell you to be cautious and really just adjust a few things when you're beginning at just learning how to scan. And there's a few buttons that are easy to use and you can use quickly without going down a rabbit hole and having a blob just show up on your screen. So compression is going to increase your dynamic range. So your weaker signals come through. You can increase it and have a softer, grayer look, or you can decrease it and you'll have a nice high contrast look. Just remember, when you change your compression, you may have to readjust your gain. The focus is a way to concentrate your ultrasound beam at a specific depth to maximize resolution there. It should be placed optimally at or just distal to the region of interest. But keep in mind, some machines don't have a focus, they autofocus, and it's not something you can change or control. You can magnify or zoom your image. So what you will do, magnify simply just takes whatever in your pie and makes it bigger. Your frame rate doesn't increase. You just twist your button and there you have a little bigger image. If you want to zoom your image, what you do is you hit the button, you're going to adjust your sector size, hit the zoom button again, and then it's going to rescan with a higher number of scan lines. So you will have an increased frame rate. And it's just a way to improve resolution of something you need to look at up close. So I've got my optimized depth, I have nice gain, my 2D settings look good, my sector width is great. So I want to save an image. How am I going to do that? If you're going to save just a frozen image or a Doppler tracing, you're just going to hit freeze and hit acquire. But I need to save a loop now or a moving clip. So you can either save an image based on beats or time. So it will acquire 3 cardiac cycles if you set it to 3 beats, or 10 seconds if you want to do a nice sweep. You can acquire retrospectively, which means you hit the acquire button, it's going to take the prior 3 beats, or prospectively, you hit acquire, it's going to take the next 3 beats. And this is just driven by your lab and their protocol and how they like to do things. A couple other knobs you need to know about. The invert image, the up-down invert button, it's generally on the first page. In pediatrics, we use this frequently. We invert the apex. In the subcostals, we're going to invert also. Just one touch, very easy to use. And so remember that the 2D button here will just turn off Doppler. It will reset everything except for your depth and gain. But sometimes you have Doppler on, you've got color on, and you're like, I just need to see a picture. Just hit 2D and that's your home base. So we're going to get into the Doppler knobs. You need to know where the cursor is, your pulse wave or tissue Doppler, continuous wave, M mode, and color. All the buttons you'll notice are right above the trackball, so they're easily found. Like I said, the 2D button is your home base to reset just to 2D. And then when you're in a Doppler modality, the 2D update allows you to toggle between live scrolling spectral Doppler and live 2D imaging without changing your display. This is a way to learn how to scan a little more quickly, and it takes a little bit of practice. And this is when it's handy to ask your sonographer, how are you doing that? So what makes a nice Doppler image? Your waveform should be 2/3 of the display. Your scale should be optimized. You shouldn't be measuring anything above the displayed line. Your baseline should be adjusted so you can see flow above or below, and your waveform should be crisp and defined. Overgaining your waveform can lead to inaccurate measurement, and undergaining your waveform can omit important information. How do we use pulse wave? So you're going to engage your cursor and you are going to place your sample volume in your area of interest. Like in this image, it's in I think the LVOT. You're going to then hit a pulse wave knob and your Doppler will start scrolling. You then want to adjust your scale and baseline, and then you can hit freeze and acquire your image. Some machines allow you to change the scale or the baseline after you freeze, but it just depends on your machine. You can also usually adjust the gain. You can add color, B mode color to the Doppler so it looks a little better, whatever you decide. And remember, as we talked about the physics, if you have aliasing velocities, you have to switch over to CW. So continuous wave, again, you engage your cursor, you're going to place it in your region of interest, you're going to hit your continuous wave knob, and your Doppler is going to start scrolling. Adjust your scale and baseline. You can use iScan and it will adjust your scale and baseline for you. It's just personal preference. When you see 3 or 4 waveforms go by that you like, usually your sweep speed's 100 because of pediatric heart rate, you're going to freeze and hit acquire. M mode, same concept. You're going to engage your cursor, direct your M mode through your desired structure, and then you're going to hit M mode. It's going to start scrolling live. You wait for a few to go by till you see one you like, hit freeze. You can adjust your gain. And some machines allow for anatomic correction when your cursor isn't able to line up perfectly on axis. Color Doppler. Everyone should know that blue is away from the transducer, red is flowed towards the transducer. You need to optimize your 2D image first. So have your sector size optimized, your depth appropriate. Your color box should be tall and narrow, but it's better than short and squatty. You don't want to put a color box over your entire sector. Your frame rate will be terrible, and frame rates already drop when you start to engage in color flow. So when you hit color, you're going to have so many choices here up on your screen. This is another place you can get into the weeds where you start changing too many buttons. So when you're first learning, you want to gain proficiency on the basics, focus on getting the views, and then later when you're good at that, you can explore these more in-depth settings. So the easiest knobs to get familiar with color, you're going to adjust your scale or your Nyquist limit. You want low flow, lower scale for low velocity flow, higher scale for high velocity flow. You want to adjust your color gain. You can increase it until it speckles and then back off a little bit. You can use the color compare button, and that is very helpful. It's a 2D image on the left with the same image on the right with color on, and it can be very useful, but remember your frame rate is going to drop when you add color. The sub mode preset is something that is really helpful for fellows. So let's say you're trying to image coronaries. You have color on, you hit the coronary button, the machine will automatically decrease your scale, increase your right priority, make adjustments that you would need to do manually, but it will do it already for you quickly. It's very helpful. And on the GE, they have a quick app. It's the same concept. So the image here on the left shows a scale that's too low and it's suggesting there's turbulence in the outflow tract. And then on the right, we have the scale optimized, showing that it's just nice laminar flow. So my 2D image is still not great. What can I do? Well, the easiest thing to do when it just looks like this is a mess, you're going to reset your probe. Go back to that first screen, reset your probe. You can switch frequencies on your current probe. Maybe you need to switch to the res setting or high frequency. Or you can switch to a different preset on your current probe. Our 5 probe, we have a technically difficult setting for big teenagers that have tough windows. You can just switch probes completely. Maybe you need to get the 9 probe to try to get coronaries on a teenager. It's worth a shot. and you can reposition your patient. But remember, ask a sonographer. We love to help fellows get acquainted with buttons, show them our tips and tricks. Please ask for help. So remember that image optimization takes technical skill. It's gained through repetition. If you know your protocol, this will allow you to master the knobs and anatomy and not have to think about your protocol. I think it's great to ask to be quizzed. We have a competency tool that we use for our fellows that they check off on all the knobs on the Philips and the GE, and it's just a great way to get acquainted with the knobs. And the last thing that I want to leave you with is keep it simple. Don't make it harder for yourself by messing with a ton of buttons at first. Scan as much as you can, and you'll become an expert at knobology. Just like this group of fellows that I work with that I love. Thank you so much.
Thank you so much to all of our speakers. They were all very excellent. Or just stop sharing for a moment so that I can
let me
share
stop
the last
sharing.
slide.
There we go.
Thank you.
Yep.
All right, so we have our second session, which takes place on September 12th, which we're all looking forward to. It's going to be Dr. Parnes speaking about something he's intimately familiar with, segmental cardiac anatomy. Please join us for that, and please spread the word if you found this first session helpful. I expect the second session to be equally, if not more so. I'd like to thank all of the moderators and my co-champion for this event, as well as our sponsors. If you are interested in becoming a sponsor, please let Tara Foy know, who you received the SOPE emails from. And if we have questions, we can start with the Q&A.
All right. Well, yeah, we had a kind of a good question earlier on in the session. I think it'd be fun to hear from all three of our experts who spoke to us tonight. And it was, if you were on a desert island and can only choose one view, which one would you choose? And so, Dr. Ho, I thought we'd start with you since you spoke to us about our standard echo views.
Oh, yes, I agree with Jennifer completely. I would absolutely want the subcostal. Do I get both subcostal sweeps? Ideally, I want both subcostals, but I'll take the subcostal long axis or frontal. That's enough for me. I alluded to this when we were going through the images, but you can get so much information, not just within the heart, but also above the heart, great arteries. Sometimes in a baby, you can see the innominate vein coming across. You can see a lot of stuff in that view. So absolutely, I would vote subcostal.
All right, what about you, Dr. Burkett?
I agree, subcostal. And for a few reasons. One, I think it gives you a huge amount of cardiac information. We do echo readouts where we literally will go through one subcostal sweep for 30 minutes or an hour and define all of the heart disease based on that. But it also is not a cardiocentric view. So following the heart into the different places, you lose the relationship of where the heart is with the other structures that are outside the heart, whereas the subcostal, if you're in a body-centric view, you get more information about the relationships with the heart and its space.
And Laura, are you also a subcostal fan?
I'm going to have to agree. Yeah, I like the subcostals too. Definitely, especially a new baby. Yeah, it's the money shot.
Our next question would be, what makes a great imager in your opinion?
Should I go first? I really like a lot of the answers in the chat. I think it's so true, pediatric cardiology. The reason that a lot of us love pediatric cardiology is anything that can happen will happen. You know, even the most senior cardiologists will every now and then in surgical conference say, I've never seen that before, you know, it'll come across something crazy. And so really, you know, I tell my fellows, when you start an echo, anything is possible until you've seen for sure in multiple views that pulmonary vein connects the way you think it does. You know, your differential basically is everything, and then you slowly cross those things off as you prove, yes, in fact there are two ventricles, yes, the mitral valve does open. You know, you slowly, you know, whittle away at the possibilities. And so keeping your mind open, or being humble, and really really wanting to prove that, I think is critical.
Yeah, I agree. And I put that in the chat. I think, you know, we can teach you in 3 years to be very good imagers, or at least pretty good imagers. But I can't teach you to like want to be good. So the desire to go back and get the extra pictures at the end of a study when you think that you've gotten everything, and you know, like, I didn't get the coronaries, but I'll just have this sonographer go back and get it. Or overnight when you just want to do like the 10 images on this patient rather than doing a full study. I think those are the points where you're pushing yourself to get better, where you will have kind of an exponential growth in your ability to image above those who don't push themselves like that.
I think in my experience with fellows, the best ones are the ones that, like you said, they don't want to give up, and they keep at it, and they don't hand the probe over, and they swat my hand away when I try to start messing with the knobs for them. To me, those are the people that are really thinking about all the things you think about, not just getting the picture. And they ask a lot of questions. So I think you need to be humble and ask questions and be willing to listen to sonographers who we might have a different background than physicians, but we still know quite a bit and can really help. And I think that really helps, having an open mind and listening and wanting to figure out the puzzle. We all love that new baby that we don't know what they have. And the fellows that want to scan that, that's a great thing.
Great, thanks. I think I'll throw this next one to you, Dale. Can you give us an example of a time you tried tuning harmonics on or off to optimize your image?
Yeah, I think especially when you're imaging things that are deeper. So this is going to be more, I guess, effective and helpful when you have larger patients, things are further away. That's really where you're getting attenuation of signal, but harmonic frequencies might be playing a bigger role. And again, there you sacrifice things like grayscale, and sometimes things look thicker. So that's an important thing to recognize as somebody who reads echoes. Sometimes you'll see an echo and you say like, man, that valve looks a little bit thick. That's kind of unusual. But then you recognize that something is in harmonics, and it may not be actually as imaged, but that's probably the most helpful time. So I would say generally trying to image in fundamental frequencies is usually the most helpful. Especially for a lot of pediatrics. It's when you start getting to the bigger people that you're going to have to start going into your bag of tricks.
So the next question is geared more towards fellows who are at smaller programs who may not be as comfortable with complex lesions because there just aren't as many of them. How do fellows get familiar with echoing those patients?
I think that even in a small program that maybe you're not seeing a new baby, you know, multiple times a week, your institution has seen those complex babies. They exist in your database, it's Singo or wherever it is, and sitting down and learning how to understand that image as it's happening will help you when you have to do it yourself. Because to a degree, especially if you're imaging a complex new baby, you have to both take the image and read the image, which I do like to tell fellows. I mean, maybe there are senior imagers out there who can do it, but I can't do both at the same time. If I'm trying to take a good picture, I'm focused on making sure that I'm keeping the image in the space I want it to be, doing a really good sweep, keeping my tempo at the right pace. And then I will actually do my clip and then separately do a sweep for myself where I'm trying to interpret the image, understand what's happening so that I can make a plan for what I'm going to do in the rest of my study. And so part of that is gaining familiarity with looking at something that isn't where it's supposed to be. And I think it all comes down to pattern recognition. And so if you can take the time to go back through your institutional history, ask the attending, what's the weirdest patient you've seen, or you see a heterotaxy patient in someone's clinic, go back and look at their initial echo. Spend a lot of time really looking at those sweeps, trying to understand them so that you have the benefit of that secondary experience, even if you're not the person with the hand on the probe at that time. And then, all of those wonderful normal babies that you've scanned, that will click in as you're doing it, so you know how to optimize those images to answer the question when you do come across that complex new baby. But I think no matter what size your program, there's going to be those complex, weird patients, and they're there for you to look at.
Yeah, I would echo that. I think there's a couple things. One, there's like these models and demos. Some of those are very expensive, but they have like pre-programmed congenital heart disease where you can actually go put a probe on this model and scan it, and it looks like hypoplastic left heart, and then you can tell it look like a TGA. So it'll give you images that are consistent with those things, even if that's not something that you regularly see. But I can't agree enough with go back and look at the images. I think as painful as it is for our fourth year fellows to do surgical conference where they present echoes, I think it's probably the biggest point of learning for fellows is to actually pour through image after image after image of a patient and really understand. You have the report there with an expert who says this is all of the findings, and now you can go back and match those findings with the images. I think it's a great way to learn congenital heart disease. And then lastly is try to get in scanning, even if you're not on an echo rotation. Be willing to get the machine out in the middle of the night on call and go scan the kid in the ICU. And the more that you do it, the more that you get the reps in, the easier it becomes to understand some of those congenital heart disease things that might be pretty uncommon in your institution.
I have nothing to add. Those were great answers.
All right, wonderful. I think that was a very robust discussion. For the sake of everyone's evening, at least on the East Coast, I will cut it off there. But thank you again to all of our speakers for a great session. Once again, our SOPE session is our SOPE bootcamp session is not yet done. We have a second session with Dr. Parness on the 12th. And as a clarification, there is going to be another registration link that goes out from Terrafoy from SOPE. So look out for that. Sign up, please spread the word, and we'll see you in a couple weeks.
Thank you very much, everyone.
Thank you.
Great job, all. See you in a couple weeks.
Thanks.